Good afternoon, everyone. So today I'll be presenting this is an important abstract which has used the utility of the extended interval dosing of the Denosumab in patient with metastatic carcinoma prostatic cancer. This is basically conducted by the Indiana University and presented in ASCO 2025. So before going towards the abstract, we all know that there are the bone modifying agents like zoledronic acid and Denosumab. So this is the most important trial because this trial's data was used as a historical comparison in the main abstract. So this is a Fizazi et al. Presented in 2011. This is a phase 3 randomized data. This trial had done the head-to-head comparison between the standard dosing Denosumab and the standard dosing of the zoledronic acid. And the primary endpoint of this study was time to develop the first skeletal-related event. The definition of skeletal-related events were the pathological fracture, the radiation therapy, the surgical intervention, and the cord compression. So this trial was specifically analyzed initially for the non-inferiority trial. So this is a baseline comparison between the all patient subgroup in terms of the age, race, performance status. Here we can see the time to develop the first skeletal-related events. It was better, slightly better in case of the Denosumab compared with the zoledronic acid. It was 20.7 month versus 17.1 month. The hazard ratio and the p-value was also statistically significant both for the non-inferiority and superiority data. Even for the subsequent skeletal-related events, the Denosumab did better job compared with the zoledronic acid. But if we will see the overall survival data and the progression-free survival, both Denosumab and the zoledronic acid, they were similar in terms of the outcome. In skeletal-related events, the most common was the radiation to the bone seen in 21% of the patient and pathological around 15% of the patient. So FDA has already approved the zoledronic acid as a standard dose every 4 weekly, but in our routine clinical practice, somehow the using 3 monthly, the bone modifying agent is also very commonly practiced because of the patient convenience. We have a very good data for zoledronic acid, however for Denosumab, we have a very little data. So let's see the extended dosing data for the zoledronic acid. This is a phase 3 randomized data presented in 2017. This data basically compared head-to-head with the 4 weekly and the 3 monthly schedule of the zoledronic acid. And they have shown that there was a 29.5% in the 4 weekly schedule arm. It was a time to develop the skeletal-related events. However, it was 28.6% with the 3 monthly schedule. So overall, both arms were similar in terms of the primary outcome. This is another systemic review on the meta-analysis, which has used the zoledronic 4 weekly versus 3 monthly, and it has included the 5 study in the meta-analysis, and they have concluded that both the 4 weekly and the 3 monthly schedule, they were equally efficacious in terms of the time to develop the skeletal-related events. So now if we will see the data for Denosumab, we have a very limited data. This is a retrospective study published in 2023, and it has shown that Denosumab was used in this study was basically in the 3 mode. One was less than 5 weeks, that was a short-term interval. Second is the 5 to 11 weeks, which was a medium interval, and the 12 week or more than 12 week was used as a long-term interval. The primary outcome was the comparison of the short-term and the medium interval group. So this study has shown the time to develop the skeletal-related events in the short versus medium and the medium versus long-term interval. It was all equal in the all 3 group analysis. So coming to the main abstract, which has used a bone modifying agent Denosumab, which are routinely commonly in practice in the carcinoma prostatic cancer. So the frequent standard using is the 4 weekly schedule. However, the less frequent administration like 12 weekly schedule is also used because of the patient convenience. So this abstract has highlighted the efficacy and safety of the extended interval regimen compared with the historical data of the 4 weekly schedule. So total 10 patients were included and treated at Indiana University from September 2019 to September 2024. The historical group, they have taken the initial data I have presented, the Fizazi et al. In 2011. They have compared with the 4 weekly schedule, the outcome data as a control arm. So skeletal-related events were defined as a pathological fracture, the spinal cord compression, the surgical intervention, and the radiation to bone. Extended interval was defined as more than 4 weekly apart schedule on the consistent basis. So statistical analysis was chi-square Fisher exact test for the categorical variables, Wilcoxon module for the continuous variable. The incidence of the present study and the historical data was compared. So the median age of starting the bone preserving agent was around 70.6 years. 72 patients were in the castration resistant arm and 31 patients in the hormonal sensitive arm. So the patient experiencing more than one skeletal-related event at the time of starting the Denosumab, it was 22.2% in castration-resistant and in 25.8% in hormonal-sensitive arm. Among the skeletal-related events, the pathological fracture was seen in 4.2% patient and 1.4% patient, and surgical intervention was 2.8% and radiation therapy in 19% of patients in castration-resistant arm. The incidence of hypocalcemia in castration-resistant and hormonal sensitive, it was similar. Even the dental complications were also similar in the both group. So incidence of skeletal-related events in extended dosing Denosumab arm was 23.3% overall. If you will see in the cases of metastatic CRPC patient, the incidence of skeletal-related event was 26.6%. And if we compare with the historical data, the incidence of the skeletal-related event in 4-weekly scheduled arm was 35.9%. So median time to develop of SRE was not estimable in overall cohort population, but in further subgroup analysis in patients with CRPC, in extended dosing interval, extended dosing group, it was 42.8 months versus 20.7 months in historical group. In skeletal-related events, the pathological fracture was seen in 2.9%, the cord compression in 1%, surgical intervention was done in 1.9% patient, and radiation was given in 21.4% patient. So this is a Kaplan-Meier analysis showing a time to SRE development in CRPC patient. So in conclusion of this study, the extended dosing interval in the metastatic CA prostate patient, it is not associated with increased risk of development of SRE. However, we need more prospective data, more randomized data, so that we can conclude that Denosumab can be given as an extended dosing interval without compromising the outcome. Thank you for your kind attention.
Thank you, Dr. Pooja. Now I will like to invite Dr. Sayak from the Nuclear Medicine Department of our hospital, and he will present two of the abstract related to the diagnostics in the prostate cancer.
Good afternoon, everyone. So I will be presenting two lutetium PSMA abstracts. Both are combination therapy. One is in metastatic HSPC setting and another is in the CRPC setting. So the first study that I will be presenting was published in 2024. That is the upfront PSMA multi-center open-label randomized phase 2 study where they combine lutetium PSMA with docetaxel and compared it with docetaxel standard of care in metastatic hormone-sensitive prostate cancer, high-volume disease. So from the CHARTED trial, we know that addition of docetaxel with standard androgen deprivation therapy improves the survival of metastatic high-volume HSPC patients. And in this study, they hypothesized that if they add another bullet in the form of lutetium PSMA, it may achieve a higher undetectable PSA value at 12 months or 48 weeks in metastatic high-volume HSPC. So conventional prostatic adenocarcinoma patients who were metastatic with conventional imaging and had a history of ADT use of less than 4 weeks were screened with dual PET scans, that is FDG PET and PSMA PET, and depending on the favorable scan findings, they were randomized into two arms. One is the experimental arm where they gave 2 cycles of lutetium PSMA 617, 200 millicurie, 6 weeks apart, followed by docetaxel 75 milligram per meter square, 6 cycles, each cycle 3 weeks apart. And in the control arm, docetaxel 6 same as the experimental arm schedule. And the primary endpoint was undetectable PSA at 48 weeks, and secondary endpoints were PSA, PFS, RPFS, freedom from castrate resistance, and quality of life endpoints. So regarding a little bit of the PSMA PET and FDG PET based inclusion and exclusion criteria, so they defined PSMA avid disease as like very high PSMA uptake of ACV max of more than 15, and high volume metastasis should correspond in the PSMA PET, and also there should not be a lot of discordant FDG positive PSMA negative lesions. So initial sample size that they calculated was 140, so they based the reference on the charted trial where 27% patients in the docetaxel plus ADT arm showed a good PSA response at 48 weeks. So their hypothesis was that in the experimental arm it will be 50%, and in the control arm it will be 25% with a 85% power. So this is the consort diagram. So we can see 166 patients were initially screened. However, 22% patients were excluded due to unfavorable imaging findings, and they could only recruit patients till 130 instead of 140 due to COVID restrictions. And and treatment was commenced in 63 patients in both the arms, and for the primary endpoint 61 patients in both the arms were evaluable, and for the secondary endpoints 63 patients in both the arms were evaluable. And treatment was completed for experimental arm lutetium PSMA 2 cycles for all patients, and docetaxel, however, was only 79% patients in the experimental arm completed 6 cycles, and 84% in the comparator arm, and 33% patient in the experimental arm had to reduce the docetaxel doses. So the general patient characteristics were matching with high volume disease in 95% and 87% of the patient. Total 9% of the total population, less than 9% of total population had low volume disease. So coming to the primary endpoint, undetectable PSA value at 48 weeks. In the experimental arm, 41% patients achieved that, and in the docetaxel arm, only 16% patients achieved that with a odds ratio of 3.88. In terms of time to event endpoints also, lutetium PSMA plus docetaxel arm outperformed the docetaxel arm with a median PSA PFS of 31 month versus 20 month, and freedom from castrate resistance of 20 months versus 16 month. However, the overall survival data is still not matured yet with 36-month follow-up, so we can see that there is not much difference in the Kaplan-Meier curves. Throughout the study, quality of life and pain parameters were maintained equivalently in both the arms. Adverse effects were also pretty equivalent, 29% and 27% in the experimental versus in the comparator arm. And few febrile neutropenia and diarrhea were seen marginally more grade 3-4 in the experimental arm. And as expected, in the some mild dry mouth was experienced in the experimental arm because of lutetium. So the main issue with this trial is that in the control arm, they used androgen deprivation therapy and docetaxel. However, we know metastatic high volume prostate cancer now, based on the PIS1 data and ARASENS data, that you should add a triplet therapy by adding a androgen receptor pathway inhibitor. Relatively small sample size, and they also couldn't recruit till their sample goal of 140, so which decreased the power a bit. And also they had a very stringent PET-based criteria which may hinder wider application, and addition of FDG PET might increase the cost of further treatment. So this was the first trial of lutetium PSMA in a metastatic HSPC where the primary endpoint was achieved, and the lutetium PSMA plus docetaxel had a greater activity versus docetaxel alone with acceptable side effects, toxicity profile. The second study that I'll be presenting is the lutetium 617 ENZA-P trial, 617 plus enzalutamide in early chemo-naive CRPC. This is also a phase 2 trial. So the original study was published in 2024, but there is a secondary analysis of the trial which published in 2025 and was presented in GU ASCO. And this slide deck was provided to me by the organizers. So I thank them. So as we know that PREVAIL trial established enzalutamide as like useful agent for treating a CRPC patient. And in the recently concluded PSMA-4 study, we saw that in early chemo-naive CRPC patient, lutetium PSMA outperformed second-line ERPI switch therapy in terms of improved radiological progression-free survival. However, it didn't show significant OS benefit. So in that study they had concluded that probably that is because of the 57% crossover from the lutetium PSMA arm to from the standard of care arm to the lutetium PSMA arm. So why do we want to combine enzalutamide with lutetium PSMA? So with enzalutamide, there is downregulation androgen pathway, which indirectly influences increase in cell surface expression of PSMA receptors, and which would in turn increase lutetium PSMA uptake, thereby delivering more radiation payload to the cancer sites. So in this study, chemo-naive early CRPC patient who had at least 2 risk features which would preclude them, which would make them early failure of enzalutamide, were randomized into 1:1 into enzalutamide alone group, where 160 milligram enzalutamide was given daily, plus and in the experimental arm, enzalutamide 160 milligram plus lutetium PSMA 2 to 4 cycles were given. And the PSMA